Good afternoon, everybody. My name is Tracy Naledi. I am the Deputy Dean for Social Accountability and Health Systems. Apologies that we starting a few minutes late. We are aware that there's been a challenge with sending the link. So please assist in terms of sharing the link to join the meeting with as many people as possible. And we've resent an email with the link. So hopefully our colleagues will join us as soon as possible. Welcome to this very exciting webinar today around gender-affirming healthcare, looking at the evidence, ethics, and access. This, we hope, is more than just an academic gathering, but a part of our shared journey as a faculty towards our major transformative purpose of igniting agency for a just and inclusive society built on health equity. Over the last few years as a faculty, we've experienced both challenge and learning following public debates, even affronts on trans health. We've turned to listening. We first did a transformation survey in 2021 that highlighted that many groups within our faculty do not feel that they belong. And as a faculty, we've done a lot of work around improving a sense of belonging for all of us. This has not been a single event and continues to be a journey that we are part of. We are on a journey of. With regards to trans and gender diverse people in particular, we have engaged with people with lived experience. Last year in March, had a fantastic symposium where we heard from those who are living with their experience, and they could reflect on how they feel on their lived experience. And we've also convened a meeting where we had a weekend-long symposium in partnership with the DTHF, the Desmond Tutu Health Foundation, and our civil society partners, where we were deepening our collective understanding of what health for this group looks like, what it requires, what the gaps are from a service perspective, from a teaching and learning perspective, and from a research perspective. Today, we continue this conversation, and even today, this is not the end of a conversation, and we hope we will have other conversation. This particular conversation is designed as an open space that is grounded in evidence, guided by ethics, and a commitment to supporting access for those who need it. It is a space where we hope we can bring scholarship, advocacy, and lived experience into dialogue, to not only reflect on where we are, but also to imagine and act on what is possible. And as we do this, it feels especially meaningful that tomorrow we mark Heritage Day in South Africa, a reminder of the richness of our diversity as a country, the struggles and the triumphs that have shaped who we are, and the responsibility we share to honor every person's dignity and humanity. So let us carry this spirit of Ubuntu with us as we go into this conversation today. I invite each and every one of us to engage with openness and courage, to listen deeply, and to speak in ways that strengthen our collective pursuit of equity. Together, we can transform research, teaching and learning, service delivery, and debate into action and solidarity. Thank you very much for joining us. And I would like to begin by introducing Professor Linda-Gail Bekker, who is the director of the Desmond Tutu Health Foundation, who's going to be the facilitator for today. Over to you, Linda-Gail.
Thanks, Tracy, and a great pleasure to join all of you this afternoon. Apologies again that we started a little bit late. We have a full program, so I'm not going to take too much time except to say that it is my honor this afternoon to moderate this conversation, and we hope that indeed it will be that, an opportunity for shared learning, shared experiences, and really gaining through dialogue. It is important for us to know that transgender and gender diverse people face multiple barriers to medical care. A 2019 systematic review found that up to and more than 27% of such individuals had been denied care by a health professional. A 2018 study of primary care clinicians found that 85% were willing to provide care for transgender and gender diverse persons, but 52% were unfamiliar with healthcare guidelines for transgender and gender diverse people. So we recognize that this is a topic that needs further discussion, exploration, and we definitely need input. Many of us are not expert in it. I include myself amongst those. And so I'm delighted this afternoon that I'm able to present a series of individuals who've thought deeply about this, have committed their careers to these and other patients, clients, individuals who find themselves in a situation where they may be questioning the sex that they were assigned at birth, and need help, need our help as healthcare providers in order to really fulfill their lives and again realize well-being. Many of you may be concerned. You may be lacking information. Some of you may, in fact, be skeptical of this, even that this condition or this situation or this phenomenon exists. And I think it's important that we say to you that we are not dismissing anybody's viewpoints or ideas this afternoon, but what we are hoping to do is provide evidence-based information and dispel perhaps some misperceptions or conceptions that need to be reviewed. And I think if we can place within this our wish to provide the best possible health care that we can as a faculty, as a sector, and that we position young people, adolescents, in the very center of this discussion, looking to find ways to provide person-centered care. So with that, I'm very happy to quickly move into the program. We will go through a number of presentations, each of them 10 minutes in length, and at the end of that, we will allow members, people participating in the webinar to place questions, concerns, ideas, commentary in the Q&A box. We'll be monitoring that box and we will lift out of that questions that we will then be able to put to the panel and try and address as many of those questions as we can this afternoon. Those that we are unable to get to, we promise that we will collate and respond in days and weeks to come. And where perhaps a quick answer is possible, that answer will be provided in the Q&A box. So please feel free to place your questions in the Q&A box this afternoon. So I'm going to introduce each speaker as they come up. And in the first instance, we turn to Sorrel Pitcher, who is an expert on gender. She, in fact, completed her PhD on this topic, and her topic this afternoon is a psychosocial exploration of why gender-affirming care is important for youth. And with that, I'll hand over to Sorrel.
Hi, everyone. First of all, thank you to UCT for inviting me to be part of this discussion. This is something I'm really passionate about, and I'm really grateful to be a part of this discussion. I'm just going to share my screen quickly so that, excuse me. No, I haven't done this in a while, so please forgive me. Can everyone see my PowerPoint presentation?
Yes, that's perfect. Thanks, Sorrel. So 10 minutes.
Yes, thank you. So just to quickly outline what I'm hoping to achieve with my segment of this discussion. So first of all, just to say that I am a clinical psychologist in private practice, and I have a particular interest in working with sexually and gender diverse persons, particularly young people. So today I'm just going to be looking at, first of all, paying attention to context and how mental health with trans and gender diverse persons is very much impacted by context. A very quick look at what the research says about trans and gender diverse persons and mental health. And then I'm going to mostly focus on centering lived experiences and voices of young trans and gender diverse folks. And I'm going to be using this, I'm going to be using some research from my master's thesis in 2018. LGB, unfortunately, I do not yet have my PhD, but I am hoping to get there one day. And just to note that participants have given consent for their data and the content that they shared in the research to be used in talks such as this. So first of all, I think that there is in some spheres a misconception that being transgender or gender diverse comes with kind of inherent mental health issues. And so I would just like to challenge that belief and rather paying attention to the system. And I've used the spelling of the word system as it conflates the word system and cisgender, and thus highlights the systematized power which oppresses, subjugates, and marginalizes transgender people. So this neologism captures the way in which everyday systems and institutions uphold cisgender heterosexual identities and as the norm, and therefore assign legitimacy to certain groups but not to others. And therefore, I think it's incredibly important that when we are working with trans and gender diverse youth, that we don't just pay attention to each person's individual context, that their home or family environment, but also looking at the broader social, political, and historical contexts that shape their lived experiences and internal worlds. As we know, we do not exist in isolation. And the amount of care, access to care, and supportive social frameworks that young trans and gender diverse people have a massive impact on their mental health and their physical health. So it is well documented in international and local research that trans and gender diverse youth experience higher levels of depression, anxiety, suicidal ideation, and suicide attempts than cisgender youth. And as I said earlier, this is not because mental health issues are inherently a part of being trans or gender diverse, but rather that there are multiple internal and external stresses that make things more difficult. So what lies beneath the kind of research statistics that we have, and that's also part of my purpose here today, is to focus more on lived experiences and maybe more hidden internal experiences that aren't talked about as much. So if we think about external stresses, given the cis heteronormative societies that we generally live in, trans and gender diverse youth are much more likely to experience violence and discrimination based on their gender identity, social rejection, barriers to accessing education, healthcare, and employment. So just in terms of external obstacles to navigate, there's a much higher load that trans people need to deal with. But then there's also a heightened experiences of internal stresses. So what I'm talking about here is the experience of internalized shame and stigma, constant hypervigilance, needing to, am I safe here? Am I going to be included in the space? Feelings of identity incongruence, so feeling that your external gender presentation or physical presentation does not match your internal gender experience, gender dysphoria, anxieties about survival. This brings to mind a young person I worked with a few years ago who was explaining in quite detail to me how he felt it wasn't really worth planning to write his matric exams because he didn't see himself surviving beyond 18 years old or beyond high school because of the context that he's in. Along with low self-esteem, low self-efficacy, as well as an increased cognitive load and mental effort, which I think is something we also don't think about, is how much one needs to think about how they show up in spaces. Am I going to be safe here? Do I need to present myself in a certain way? So yeah, just thinking about the layers of internal and external stresses. But what we have also seen in research is that when transgender youth are able to access gender-affirming healthcare, that we see a decrease in levels of depression, anxiety, and suicidality. So obviously being able to access gender-affirming care does not address all of the stresses that have been outlined here, but it does assist with many of them. And that's why it is such an important part of trans and gender diverse youth's healthcare overall. So I'm going to be speaking about, some lived experiences, and these narratives and photographs are coming from a photo voice project that was conducted in 2018. I'm not going to go into great detail about the methodology. There is a paper written about this if you would like more information. But just to give a very brief overview, it was a photo voice project. So this makes use of participants' narratives and photographs as part of data collection. And this project involved 5 trans or gender diverse identifying participants who were between the ages of 18 and 16, and they reflected on their childhood and adolescence in Cape Town and growing up in this space and what that meant for them. So these excerpts that I'm going to be sharing with you are meant as a snapshot of lived experience, as a way to highlight and center teen and child's mental well-being. And also just to say that this was obviously a very, very small sample size, and that was mostly with white middle class, trans and gender diverse people. So not a representative sample, but it is a good indicator of a lot of much broader issues that we're going to be discussing today. So this quote is from a young trans man who we used the pseudonym C. And he is speaking about kind of how everyday obstacles as a trans person. So the obstacles we face are more than just getting past the way people see us or how we are expected to act in order to become who we are. These obstacles are rather the things we have to go through in life. Most of the obstacles are simple things that are normal to others and almost seem pretty everyday to most people. Things like filling in forms, because this requires legal names. And when you haven't legally changed your name, this can be one of the most difficult obstacles. So what C is referring to here, I think, is also what I was highlighting earlier about the extra cognitive load or mental effort that needs to go into navigating what most people would experience as everyday things that don't require much effort. But what does it mean when one has to constantly think through a whole lot of other details around, for example, just filling in a job application? And what does that mean in terms of added stress, added anxiety? And what does that mean in terms of a long-term for mental health? So this is a quote from E, who is a 22-year-old genderqueer individual. And here they're speaking about their experience of being at school, not feeling seen or safe in school, and how this led to them, I guess, becoming physically ill in other ways. So E said, I developed a kidney condition because I would not go to the bathroom at school. And it really just messed with me and my anatomy and just did terrible things. And I still have that kidney condition. Because I would never go to the bathroom at school because there were no gender neutral bathrooms, nothing that I could go to. And I would always just wait until I got home, and the day is very long. It's like one of the worst things that I experienced with regards to being genderqueer in high school. You know, so there's that. And also I didn't feel coming out in high school, and I wish I had been able to feel safe to do that because it would have solved so many things for me and just helped me a lot emotionally and psychologically. I was held back by rules in an environment that wasn't really incorporating or encompassing anything that or validating anything that I was feeling. So E touches on a number of issues here, but I think what it also highlights is the intersection of access, safety, gender affirming care, and also just general physical health conditions and how those can all intersect. And really what E is speaking about here is that if they had felt more emotionally and psychologically supported in their transition, in their gender identity, and if they'd had access to a bathroom that reflected that, their health might have been very different into adulthood. So this quote particularly speaks to accessing gender-affirming healthcare, and it's by B, who identifies as gender neutral. And they speak to, I guess, what is being called experiences of gatekeeping and B's questions around this. So I suppose in a way it felt like there was always this, I don't know, the sort of like thing that I needed to achieve to be able to start transitioning. But it was always like out of reach. And I really struggled with that because, I don't know, like I realized it's important for someone to be stable. And here B is referring to mentally stable and everything like that, to be able to go through transitioning and stuff like that. But then I also have been very angry about gatekeeping and everything like that. And I never really know what is the truth. Like how much of it has been gatekeeping and how much of it has been sensible. And I think B makes a really interesting point here in terms of, I think what a lot of people have spoken about is how the caution around allowing young people to access gender-affirming care can often be interpreted as gatekeeping or even harmful. And B's speaking about how for them, in their experience, it was very difficult for them to ascertain how much of this is good mental health care advice and how much of this is preventing access or preventing gatekeeping. And that makes it difficult to trust, to build relationship with healthcare providers, and to also trust that one's best interests are being held in mind. And a concept that came up frequently in the research was this of hyper-invisibility. And I think this captures a lot of some of the internal distress that I was speaking about earlier. And this quote from Johnson and Bailon states that when bodies are marked as absent and present simultaneously, it results in a fourth form of visibility, hyper-invisibility. Hyper-invisibility describes a space where bodies are visible, but in limited ways that tend to mark those bodies as even more invisible. I'm going to just draw on two quotes quickly to explain this concept further. So these are two quotes from D and from M, speaking about hyper-invisibility. You always feel watched and judged, and like you've got the spotlight on you so that everyone's looking, you know? It's more like the constantly feeling judged and watched, and that you must keep acting a certain way because you feel like you're in the spotlight. People aren't always watching you for the right reasons or watching you with purpose or intent or things like that. And then M's comment, well, I basically face misgendering all the time. I get objectification because I'm seen as a woman, but only when I look a certain way. You know, it depends. If I look more masculine, then I get noticed more. But if I look, for example, how I did with my longer hair, I felt more invisible, but yet seen as unattractive. So I had to choose. Do I want to be attractive today, even if I'm seen as a woman, or do I want to be ugly and completely invisible? So D and M here are both speaking to how in certain ways they feel they are almost surveilled or watched in public because of their gender expression, but in other ways they feel invisible or not seen, and that there are very few spaces or people that they feel like they are seen as they wish to be seen. And the incongruence, the internal distress of needing to balance other people's expectations of their gender expression, and the exhaustion that came with this, the fatigue of needing to present in certain ways to feel safe or to be seen. So in this very, very brief look into lived experience, access, safety, and mental health care with regards to trans and gender diverse youth, I think it's important for us not to get stuck in narrow narratives of risk and trauma when it comes to trans youth, but we also do need to recognize, acknowledge, and sit with others' pain and suffering, as an important way for empathizing and understanding what one's healthcare needs are. And that is where I'm going to leave it for today. Here are my references. I've given more of a humanities psychological input, and the rest of my colleagues are going to explore evidence-based, biomedical, legal frameworks. Thank you, everyone.
Sorrel. Thank you.
I hope I kept to time. I think I kind of did.
It's okay. I think we'll manage. Thanks, Sorrel. I'm going to quickly move on, but thank you deeply for sharing some of those lived experiences. I think so critical for us to start from that standpoint. We're now going to move into evidence. Do we need it? And here we are happy to have Professor Mark Blockman, who is the head of, who chairs our Human Ethics Committee, Research Ethics Committee at the faculty, but is also a pharmacologist. So over to you, Mark. Thank you. If you're speaking, Mark, we can't hear you. We do see your slides.
I'm concerned that Mark may have dropped off.
Ah, okay.
I haven't. Can you hear me now?
Yes, I can. Thanks, Mark. Great.
See my slides in presenter mode?
Yes, beautiful.
Wonderful.
Go ahead.
So thank you very much for inviting me. And I thought I would just take you through the journey around evidence. Do we need it? And part of the discourse has been around some of the evidence and the way people look at evidence. And I thought I would just do a little journey around, do we actually need the evidence? So this is, well, that's a relief, Doctor. Don't worry, Mr. Smith. I'm right 98% of the time. My motto has always been, who cares about the other 3%? A systematic review looking at clinical experience and quality of healthcare suggests that the longer we are in practice, the worse we remember and the worse we know, which requires us to maintain our evidence. And I'll get back to you around eminence later on. Sydney Burwell said, my students are dismayed when I say to them half of what you were taught as a medical student in 10 years will have been shown to be wrong. And the trouble is none of the teachers know which half. And here's just, I've got two examples on where the evidence has let us down. And this is practice based on theory. And this is ventrilateral fibroplasia. And this was Silverman in 1977. It was a Scientific American. And they looked for the cause. And they had thought initially that high-dose oxygen was suspected, as there was some anecdotal evidence in 147 infants. Another observational series of 479 infants claimed some benefit. And one study attempted to lower the oxygen dose, but nurses wouldn't turn the oxygen down at night because they thought it was unethical. So in 1953, the NIH had a conference and they thought, well, we needed a control study, and others thought that the oxygen was really convicted. So they did a randomized control study on 800 infants in 1953. And when you look at the data in terms of the people that the infants that were blinded on standard dose oxygen, 23%, and 50% oxygen for the clinical indications only, 7%. And they also found a dose response. And in 1954, they published these the study results, and high oxygen dose practice stopped and the epidemic subsided. However, if we look at the outcome, not before 10,000 infants had been blinded. The long-standing treatment based on theory and observation or association, the hormone replacement therapy, it was hypothesized that HRT reduced coronary artery disease, and there was some supportive data of lipid lowering, non-human primate studies and observational studies. And the observational studies, there were quite a few, and they suggested a 40 to 50% reduction in coronary heart disease risk by using hormone replacement therapy. And this was very popular. About a third of the postmenopausal women were using HRT, the second most prescribed drug. And in 2000, there were 46 million prescriptions for Premarin, which is a trade name for estrogen. And at that time, $1.5 billion in sales, and 22 million prescriptions for Prempro, where it's estrogen and progesterone. So you can see the push factor for its use. There was the HER study, which was published in JAMA, in postmenopausal women, they were looking at secondary prevention, and you already had to have cardiovascular disease. And this was estrogen progesterone versus placebo. It was randomized double blind. The outcomes were cardiovascular mortality and fractures. When you looked at the outcomes, they also looked at clotting problems, DVTs, and pulmonary embolus, with some trend for fracture benefit in the HER study. And then I'll remind you of the Wisconsin State Journal, which said sudden end to hormone replacement study. Hormone replacement study, a shock to the medical system. And this is the Women's Health Initiative, and you can see that in terms of coronary heart disease and invasive breast cancer, you'll see that in fact, hormone replacement therapy caused an excess of morbidity in this particular group of patients. And when you looked at the data, you can see that there may be a small trend and probably not enough patients in terms of the risk for death. But in fact, for every other outcome, you could see that there's an excess risk, but low but increased risk for something which were proposed to reduce coronary artery disease by 40 to 50%. And so the Annals of Internal Medicine said postmenopausal hormone therapy, how could we have been so wrong? Sackett said, good doctors use both individual clinical expertise and the best available external evidence, and neither alone is enough. Without clinical expertise, practice risks become tyrannized by evidence, for even excellent external evidence may be inapplicable to or inappropriate for an individual patient. Without current best evidence, practice risks become rapidly out of date to the detriment of patients, and this is why we're here today. So evidence-based medicine, for important questions in serious mortality, outcomes, and morbidity, we need stronger evidence such as randomized control studies. If they're not possible, we need to be very cautious and very vigilant about treatments only based on observation or association or theory, which I've just shown you in the previous slides. And so you can do the random medical news and you can say coffee may or may not be helpful or may cause glaucoma or depression in whoever, and you can randomly spin the wheel to make up your mind. And that's the problem with observational studies. They're very biased, and one has to control for that. So I'll remind you about the hierarchical evidence area, systematic reviews being at the top, and anecdotal and expert opinion being at the bottom, which I used to call grade D evidence. And it's the evidence which I'm desperate for you to believe, grade D. And you must be aware of the textbooks. They failed to recommend therapy up to 10 years after it's been shown to be efficacious, and they continue to recommend therapy up to 10 years after it's been shown to be useless. And that's because that's just perpetuated in the books. I'll remind you about the evidence pyramid and the time spent in critical appraisal. And the further down you go, the less time you spend compared to the higher up you go. And you can see the Cochrane or systematic reviews. You spend a lot of time looking at the data and making an impression on the data, and the validity and strengths of your interpretation inferences increase the longer time you spend looking at the data. So this is how do you review the world literature in terms of so many publications per day. And when you look at some data, you'll see that randomized controlled trials and systematic reviews, there's an exponential increase in them over the many years. So is keeping up to date mission impossible? And so the only way to do it is to really consider an evidence-based medicine journal where somebody has collated the data for you. And when you start looking at the numbers of journals, in terms of the numbers needed to be valid, you have to read about 20 to get a valid outcome. And is it relevant? The numbers needed to treat is about 200. And that's the push to get you to an evidence-based medicine journal where somebody has done the work with integrity and in unbiased fashion. And then how do you find the best evidence? And how do you judge the validity? And this is where colleagues often make an error in just these six questions which are not answered. Is there randomization with concealment? And often the old days where you hold up the envelope to the light to see what the randomization looked like is very problematic. Is there proper follow-up? Is it intention to treat? Is there adequate blinding of the treatment when it's possible? And are the groups treated equally, and are the groups similar at start? And it's very easy to go through this from a critical appraisal and make up your mind if this is a good study or a poor study. And just to look at effect size, because this is where we underestimate or overestimate. So what is the magnitude and then the confidence intervals? And the effect size for me is very important. And often journals look at relative risk reductions. And I want to remind you that absolute risk reductions are absolutely critical. And I'll show you why that's important for us in the next slide. So when we look at the control and event rates in the top and the bottom, you can see the control rate is 50% and the event rate is 39%. The relative risk reduction is 22%. When you look at the bottom, very small numbers in terms of the control of the event rate versus the intervention event rate. But yet again, the relative risk is still 22%. And so one would look to say that, well, that's great. But when I actually show you the absolute risk reduction, you'll see that the top is 11% and the bottom is a very small number. And now when you convert that into the numbers needed to treat, and you can use the numbers needed to harm as well, you see that you have to treat 9 patients to get your benefit, where in the bottom, you have to treat almost 1 million patients for your benefit. So I wish to show you that relative risk reductions, despite the fact they're always published, you need to convert them into absolute risk reductions to have a proper, true outcome. What about it's peer reviewed, therefore it must be okay? And when we actually look at the problems, you can't actually, can we trust the editors? And when you look at the percentages of articles meeting quality criteria, these are what we call high impact journals. And look at the percentage time that the quality is actually appropriate. And these are the kind of journals that we look at to provide our data for policy development and for clinical that we use when we look after patients. We need to be very careful that we make 100% sure that the quality of the studies that we are using are actually appropriate. So what's the problem with current evidence base? Well, here's a very good study in the Journal of Clinical Epidemiology, which says that hijacked evidence-based medicine, stay the course and throw the pirates overboard. And so what's been the problems? Well, there's been focus on benefits rather than harms, very small areas for harms. There's reductionism which occurs. They use averages rather than individual risks and responses. And what we've seen is a massive increase in corruption by conflicts of interest, and especially guidelines. And I don't have the time to show you a systematic review looking at conflicts of interest which have not been disclosed in guideline development. And it's been captured as a tool by marketers and funders to push us to use the evidence. There's these large effect size in the early evidence, which then kind of dimute down to what the true effect size is. And the reason is that there's rapid communication of positive results. And we've seen this before, CNN, Sky, the results are then published of a single study. There's regression to the mean. They're often highly selected populations and industry-funded studies of high quality, but sometimes they have uneven playing fields. And when you look at this and don't get caught up too much in the picture, but you see that when you have sufficient sample size and enough people, you can see where the true effect size lies, which is less than when you started. And here's a study on a systematic review of ivermectin, and COVID wasn't too far away, where there was a massive push to use ivermectin. And when you look at the actual value, when they did a systematic review and you started looking critically, you'll see that in fact there was no benefit at all for ivermectin. And I won't speak to some of the studies that were which were removed due to issues with publication. I remind you, beware pooling of the results. And I'll remind you again of the hierarchical evidence, the systematic reviews and meta-analysis at the top, and anecdotal and expert opinion, which I call desperate evidence, grade D, at the bottom. And there are alternative approaches to medicine. There's evidence, which is maybe randomized controlled trials, the eminence, radiance of white hair, vehemence, the level of stridency, the elegance, smoothness of tongue or nap or suit, the providence, level of religious fervor, diffidence, level of gloom, nervousness, litigation, phobia level, or bravado, which I put there only applies to surgeons. And so I leave you with this. I know that most men, including those at ease with problems of the greatest complexity, can seldom accept even the simplest and most obvious truth, if it be such as would oblige them to admit the falsity of conclusions, which they have delighted in explaining to colleagues, which they have proudly taught to others, and which they have woven thread by thread into the fabric of their lives. And that's from Leo Tolstoy. Thank you very much for your attention.
Thanks, Mark. Well, that's sobering, just to remind us how we gather the evidence around which we formulate our guidelines. So thank you for just grounding us in that. We're now going to turn to a legal perspective on the subject. And for this, I'm delighted to introduce to all of you Karabo Ozar, who is the director of the Centre for Child Law at the University of Pretoria. And Karabo, I'm give you 10 minutes to just cover, and I'm sure it can only be quite a superficial look at the legal aspects of for children and this subject in particular.
Thank you so much, Linda-Gail. Good afternoon, everyone. So I've been asked to just share some reflections in relation to the law, looking mainly in South Africa, and just highlighting what are some of the key things we need to think about on the aspect of gender-affirming care for children, and also particularly looking at whether the current law is sufficient or not. Let me start by saying that I think most of us are aware that internationally, a lot of countries are looking into this area in relation to children. There's some way there has been laws that are adopted to say that children should not access gender-affirming care. There's some way there are middle grounds, and so that is why it's important for us to just reflect on where South Africa is in relation to this aspect. I want to just start by reminding everybody something that might already, everybody might be fully aware of, which is the UN Convention on the Rights of the Child. I think it's very crucial to always remember when we're dealing with children's rights, what are some of the key guiding treaties and how have we incorporated those in our law, how have we interpreted those, and then how do we then pave the way forward. So you recall that the UN Convention on the Rights of the Child is anchored on 4 general principles. There's more, but I mean, the 4 are the ones that from time have been key. Those being non-discrimination, survival, and development, best interests of the child, and more importantly, also respecting the views of the child. So there are even general comments under the UN Committee on the Rights of the Child that guide countries as to how we're supposed to interpret these provisions. Now, in South Africa, we have the Constitution that guarantees children as well as other people particular rights. And also we have the Children's Act, which I'll come to a little bit later. But I want to say that when reflecting about these issues, and particularly the central aspects being the respect for the views of children, the way we need to engage with their right to bodily autonomy and integrity, the way we need to think about their dignity, rights, and privacy, and how we balance it with their best interests. There is jurisprudence already from a constitutional court, for instance, in a case called Teddy Bear Clinic, where the court made it very clear that adolescents have the right to have their dignity respected, and that dignity must be read together with the right to privacy. And those who are dealing with children on a day-to-day basis, even in very controversial subjects, for example, in this case, the case dealt with the consensual sexual activity amongst adolescents, where there were quite deep moral issues about whether the law should decriminalize consensual sexual activity for adolescents. The court focusing on the fact that the important thing is ensuring that we respect the rights, we guide adolescents, and we actually make sure that we don't unnecessarily limit their rights or expose them to more harm by having legislative provisions that may lead to limiting their rights. As I mentioned, so these 3 rights, privacy, dignity, as well as the best interests of the child, must always be looked at together with the right to children to have their evolving capacities recognized. Now, this is something that even appears in the general comments of the UN Committee on the Rights of the Child. And this, some of you may be familiar with the fact that it requires us to look at the age of a child, to look at their maturity when they're making decisions pertaining to their health. And that we know is also not a once-off event, but a process where all those who are qualified to take children through that process must then do so in order to enable them to make those decisions. I want to come back to the best interest of the child, because one of the key issues is this idea that the law must go one way or the other, either enabling or restricting access to gender-affirming care. And currently, as we have the interpretation of what the best interest of the child requires of us in South Africa, and actually most countries that have adopted the UNCRC, we know the US is the only country that has not ratified the UNCRC. The courts have made it very clear that the best interest of a child require you to look at this particular child real life situation when they are in front of you seeking the assistance that they need. In this context, it will be gender affirming care, which I think the medical people here are better placed to define that for us. But when you have that child, you have to recognize that they have to tell their story, you deal with their story and the real life situation as they are in front of you. And this is crucial because there has been, post the case of S versus M that said this, there's been a number of cases where some arguments have been made that the law must become strict about what are the elements of best interest and they must go one way or the other. And the courts have declined to do so because they say no two children are the same and no circumstances that they have are the same. So when they come to you, this provision gives you flexibility and allows you to actually walk in their footsteps to be able to assist them. Now, the provision in relation to consent for medical treatment for children is in Section 129 of the Children's Act. Most of you might be familiar with it. You will know that there are provisions for children under 12 and there are provisions for children over 12. What I want to point out in relation to these provisions is that there is provision for consent to treatment, where the law says that medical treatment, you don't require then parental consent, but for surgical, well, if you're over 12, and for surgical, that you need to be duly assisted. Obviously, you need to consent as a child, but you also need to be duly assisted by your parents. Critical, the section also says that you must be able to understand the benefits, the risk, and social implications of that which you are consenting to. So again, there's some guidance in relation to what should be the things that one considers when you're looking into guidelines, particularly on gender affirming care in relation to children. Linked with this is the aspect that there is an issue of the autonomy of a child versus the parental authority. We are, at the moment, maybe most of us think of the position where parents and children are on the same page. There may be other instances where children and parents are not on the same page. How do we deal with that ethically? Whose consent do you get forward? How do you resolve the disputes? Because we know that these are issues that are not simple. These are issues that affect children for a long term. So how do we deal with this is something that is very crucial to be addressed as well in whatever guidelines we may want to adopt. So what I want to then come to is that if you look at Section 129 of the Children's Act, it may be that it's not as comprehensive as it may need to be, in particularly dealing with the issues of gender affirming care. It is what we have for now, and it must be interpreted as it is. But if we think about gender affirming care and actually looking at what is considered treatment, what is considered surgical, those terms are actually not defined in the Children's Act. So there may actually be a need to look at the medical provisions in medical legislation and then see how we enhance particularly the Children's Act. There may also be a need to look at then the different types of treatment or care that gender affirming children who need gender affirming care need, and be more specific in relation to how do we deal with it, whether there's need for sub-age categories or not. But what I want to caution, and this is where I'll conclude, is that South Africa has a very comprehensive and enabling legislative framework. We know that currently across the world, there is a pushback on children's rights, human rights, and we do need to, while we're being mindful and being careful about the risk versus the benefits of the medical treatments and the care, we do need to guard against a regression that may not only be in this area, but may lead or may spill into other areas and affect the evolving capacities and the rights of children to access their rights in other contexts. So I'll leave it there for now. Thank you.
Thanks, Karabo. Thank you. And I think we see this this narrative developing, starting with centering the child, the adolescent, the youth in the center of our considerations today, being sure that we are weighing up evidence as carefully as we can, and then, of course, now thinking about the autonomy and the rights of the youth, child, adolescent in our context. So thank you for that. And I'm sure there may be more questions emanating that we can unpack in a moment. I'll move on now to Professor Jackie Hoare, who is Professor of Neuropsychiatry. She heads up the Division of Consultative Liaison Psychiatry, and she is going to cover for us this afternoon ethical considerations in gender-affirming care. Over to you, Jackie.
Thank you, Linda-Gail, and thank you to Tracy and Lionel for the invitation to speak on the ethical considerations for providers of gender-affirming healthcare. I certainly don't consider myself an expert in this area, and I feel that my role as a member of the Clinical Ethics Committee at Groote is to merely provide a space and perhaps a framework to think through complex ethical issues. There is a growing body of literature illustrating the complex ethical dilemmas that may arise in transgender healthcare. These dilemmas span a broad spectrum, encompassing concerns from the allocation of limited resources, the ethics related to influencing the regular onset and progression of puberty, the justification for surgical procedures on ostensibly healthy tissue, the appropriate authority to grant consent for treatments, be it the patient or the guardians, to the determination and interpretation of an individual's best interests. In addition to these, the current socio-political climate shows instances of legal interference internationally for transgender and non-binary people, particularly youth, seeking medical care. Here, I attempt to think through these questions using a framework known as principlism, or the four principles approach, as this framework is among the most well-known in biomedical ethics. When feeling worried or anxious, or in complex cases, I find reverting to a well-known framework very helpful. Under principlism, ethical questions are informed by balancing four non-hierarchical principles. We need to consider all four of these principles: respect for autonomy, beneficence, non-maleficence, and justice. Each principle, not only one, must be weighed based on the particular elements of the ethical question being posed. Principlism certainly does not aim to supplant more comprehensive moral theories, but instead sets up a common ground or starting point from which clinicians and ethicists may discuss and answer ethical questions. The principle of respect for autonomy affirms that patients have a right to decide among clinical options based on their own values, beliefs, and preferences. For each of us, bodily autonomy and gender self-determination are emblematic of that right. While clinicians may be ethically or legally obligated to provide only treatments that are beneficial and medically necessary, patients do not have a moral or legal right to receive treatments deemed non-beneficial. I'll use an example outside of gender-affirming care to illustrate this. A patient with anorexia nervosa asks for a prescription of Ozempic. If we were to consider autonomy alone, we may consider prescribing this drug, but we do not. We consider all four principles. In gender-affirming care, it is only through understanding the individual their unique needs and circumstances, and thus it is only through respecting their autonomy that clinicians might form a reasonably accurate view of whether available treatments are likely to be beneficial. Therefore, while the respect for autonomy does not dictate that clinicians abide by any request that is autonomously made, it does require us to engage in honest and frank discussions with our patients about treatment options. This includes helping patients understand their options, the potential outcomes, and ensuring patients are fully aware of the risks and benefits of proposed treatments, as well as the uncertainties in medical knowledge. Beneficence involves an obligation on the part of the provider to act for the benefit of others, whereas the principle of non-maleficence reflects the maxim, above all, do no harm. An intervention respects the principle of beneficence if, overall, it improves the welfare of the patient or conveys some other benefit to them. An intervention respects the principle of non-maleficence to the degree to which it limits harms, side effects, and other unintended costs to the patient. These two principles are often considered together in that clinical interventions are expected to maximize possible benefits and minimize possible burdens to the patient. The principle of beneficence is the source of many ethical duties in transgender health. Regardless of the setting or clinical population, healthcare providers must notably provide services in an affirming, supportive, and non-judgmental manner. Facilitating access to gender-affirming care, such as writing a referral letter, can be an important part of beneficence because access to care could lead to improved mental health and psychosocial functioning. According to non-maleficence, healthcare providers should not cause needless harm. Further, risks and adverse consequences associated with clinical practices must be justified by countervailing considerations that reflect respect for autonomy, beneficence, or justice. Arguments in favor of withholding or delaying access to care for transgender adolescents often appeal to the principle of non-maleficence by asserting that the risks of adverse effects or regret associated with puberty blockers, hormones, or surgical interventions constitute harm. However, healthcare providers should be careful not to only focus on the principle of non-maleficence. There are 4 non-hierarchical principles. The mere presence of risk is not by itself enough to justify denying treatment. Few interventions in any health condition pose no risk at all. For instance, concerns over bone density loss associated with puberty blockers must be weighed against respect for gender self-determination, potential mental health benefits, the possibility of avoiding future surgical interventions, and the potential harms of not providing treatment. Nonetheless, scientific and developmental uncertainty make it difficult to ascertain whether a given practice respects non-maleficence and beneficence. In cases where the relative risks and harms have not been well studied, future research may determine that clinicians who withheld or delayed care may have negatively impacted the patient's welfare. On the other hand, upon further study, interventions that initially showed promise may eventually be shown to have minimal intended benefits and many unintended costs or harms. When there are doubts about the short or long-term risks of a proposed medical intervention, a prudent approach is to proceed cautiously, giving weight to the patient's wishes, autonomy, choosing treatments with potential benefits, beneficence, and starting with more reversible options to minimize unforeseen harm, non-maleficence. Such a step-by-step approach helps in navigating ethical decision-making amidst scientific uncertainty, ensuring that the principles of autonomy, beneficence, and non-maleficence are all given due consideration. However, it should be noted that gender self-determination and bodily autonomy, by definition, typically favor offering gender-affirming care. As a substantive principle, justice requires the fair distribution of benefits and burdens associated with healthcare practices. As a procedural principle, it requires the fair and impartial application of established rules and regulations, such as when allocating healthcare resources. The principle of justice reminds us that gender-affirming care should not be subject to higher requirements, for example, in terms of evidence-based or barriers than other forms of healthcare. The capacity. Preference, these are the 4 principles that we use in consultation liaison psychiatry. They're the Applebaum criteria to determine capacity. I find these particularly helpful, particularly when thinking about minors and their capacity to consent. We look for preference, which is the ability to communicate a consistent preference over time. So we never assess capacity in a one-off visit. Factual understanding. Do they understand the nature of their illness or condition? The treatment options, the recommended treatment, the prognosis, the risks and benefits of treatment, and they need to be able to communicate. They need to be able to acquire and retain this information and be able to communicate this. The appreciation of the facts. Do they appreciate the significance and implication of the medical decision and the consequences on their individual future? Are they able to rationally manipulate this information? The process that the individual arrives at the decision-making, taking into account their past preferences and decisions. The Children's Act has already been discussed by the previous speaker, so I'll move on to the next slide. A Dutch study in 2021 found that 89% to 93% of trans adolescents were able to consent, met these capacity assessment and were able to consent criteria to puberty blockers. There are some studies in cisgendered youths that have shown that adolescents may be particularly prone to rash decision-making. However, these concerns are context dependent and likely to be significantly reduced when decisions are made in a calm environment with support from parents and clinicians, which is generally the case in gender-affirming care. I'll give an example of a driving study. It was a study using a virtual reality game. It was done in both adults and adolescents. The test was to drive as fast as possible. You would win if you were the fastest person to cross the finish line. Of course, this meant that you were having to navigate potential risks along the way, like do we stop at the stop street? Do we speed through the amber line? Do we break the speed limit? The findings reported that there were actually no differences in the risk-taking behavior of adolescents and adults when doing this driving simulator test. However, if a peer, another adolescent, was put in the passenger seat, then the risks that adolescents took were 3 to 4 times higher than the adults. There's a concept of hot or cold cognition. Hot cognition referring to decisions or thinking when the limbic system is overactivated, particularly in context of high emotions, or when the dopaminergic reward or pleasure system is being highly stimulated, which happens when adolescents are in the presence of their peers or in emotionally charged situations. Therefore, providing adolescents with a calm, safe environment and providing them with time to make decisions increases their capacity to make the right decision for themselves significantly. Other studies have shown that it is not that adolescents are not able to make complex decisions. It's just that they make these decisions better if they're in a calm environment and if they have more time to do so. The 4 principles remind us that the patient must be at the center of clinical concerns. However politically fraught, clinical practice should proceed with a view of serving the interests of patients on the grounds of beneficence. The principle of justice reminds us that people with gender dysphoria, even if they are young and experience co-occurring health issues, should not be treated differently from all others. If treatment, on careful consideration, is likely to benefit the patient and avoid harm, then it would be a violation of autonomy, justice, beneficence, and non-maleficence to deny or to delay it. In weighing the consequences of delayed or denied gender care against the backdrop of diverse parental and societal views, the need for ethical guidance is clear. If the potential for regret dictated medical decisions, many other treatments that are later regretted or discontinued would also have to be withheld, which would compromise the principle of justice. The principle of non-maleficence reminds us that harm can come both from providing and delaying or withdrawing treatment. Assuming that the adolescent can provide meaningful assent or consent, one could argue that gender-affirming care should not be denied unless there is clear evidence of more harm than benefit. Thank you for listening.
Thank you, Jackie. If Anastasia is on.
Yeah, I'm here.
Great. I've introduced you, so launch ahead. Do you need
Yeah,
to
you have.
do you need to share?
No,
Okay, just
I'm
gonna speak.
underprepared, so I don't have a presentation.
Very good.
I feel like Microsoft has taken up my 10 minutes, but I'll try to be succinct about what I'm going to say. And I think, firstly, I just want to recognize the faculty for setting up the conversation. I want to recognize my fellow presenters for what I think has been a very important conversation thus far. And as you can see, I've elected not to bore you with a slide deck this afternoon. I'm going to bore you without one. But the reason that I approach these conversations with a sort of dynamic point of view is because I think it's always that the conversation needs to be guided by the context and by what has come before. And I do find myself in a position where, given some of the things that we've heard, particularly around the legal aspects of consent, particularly around psychological well-being and mental health, particularly around the ethics and the presentation just preceding mine by Jackie, it's almost as if everything that I would want to discuss today has already been covered, and I find myself in a position where I will largely be echoing some of the sentiments and really just bringing a couple of what I feel are pertinent and salient points into the conversation. So I think I need to begin in localizing our conversation in terms of not just temporaneously, but also geographically. We do know and we have acknowledged that much of the conversation around the provision of gender-affirming healthcare, and particularly as it concerns adolescents and younger folk, is a politicized one. It is a hot topic issue. It is something that is very much in the media spotlight around the world, and I think it's naive of us, and I think it's unfair of us not to recognize the burden and the pressure that this puts on clinicians who are on the ground doing the work, caring for individuals within the community. And then the reason I say that we need to contextualize this conversation geographically is because we do find ourselves in a very unique position and a very unique environment as healthcare providers in South Africa. Our healthcare system functions very differently to the majority of very well represented countries in much of the medical literature. And I think there's been some comments or some participation in the Q&A, and I'm sure we'll get to it later, around, data and evidence as it relates to the global north and the global south and so on. But particularly when it comes to another frontier that a couple of decades ago was very much a similar battleground to the environment that we find ourselves in now. And, this was around HIV and the provision of antiretroviral medications and the development of guidelines around the provision of those drugs, when this was a highly politicized issue, when there was a lot of pushback, when healthcare providers found themselves, whether willingly or unwillingly, found themselves required to become human rights defenders or activists on behalf of marginalized groups whose voices were not being heard, and who were paying the price of a very politicized discussion with their very lives, is the truth. So it's not a perfect analogy, but it is something that we have to take into account, particularly given that the conversation we have today is literally positioned less than 24 hours before what we will celebrate or recognize as a Heritage Day. And I think we do need to reflect on the heritage that we uphold and that we have inherited as healthcare providers and people working in this field, and the values that come along with that. So I'm not going to dive too deeply into evidence and ethics. I think we've heard enough about that from the prior speakers, Prof. Lockman, Prof. Hoare, on how evidence works and how the ethical principles are identified and applied. And I think that the nuances that I want to introduce here, and this is something that began to come out in Prof. Lockman's presentation, is just that when it comes to the conversation around evidence, it is a very nuanced conversation, and representing the team that sat together a couple of years ago and began to work on assembling guidelines for South Africa on gender-affirming healthcare. And I'll contextualize this just by saying that we recognized a need to put in the public domain and in the hands of healthcare providers an accessible tool that was developed specifically with the intent of being applied in our very unique setting, instead of having to rely on guidelines that were developed for a westernized world, for a global north, for Europe, for a United States of America, and try to twist them and fit them into what we can and can't do here. Representing the group that sat together to put together this document, I think it's very important for us to understand that there isn't always grade A evidence that we can draw on. I'll give you another brief example of before I did the work that I do now. I worked in TB drug trials when I first moved to Cape Town. And, as you know, this is a disease that ravages particularly sub-Saharan Africa and South Africa in particular. And in testing new agents or existing drugs that have never been applied to TB before, we don't compare them to a placebo or to non-intervention because we know it's unethical. We know that we can't withhold treatment in the name of building a body of evidence. And I'll make another reference to something that happened a long time ago, actually in the United States of America, which was the Tuskegee syphilis experiments, where a group of marginalized, disenfranchised people were deliberately and without their consent and knowledge even infected with syphilis, and then knowingly had to, or knowingly on the part of the researchers, withheld treatment from them. So we know that withholding treatment in a lot of these instances in the name of trying to collect evidence isn't a reasonable, isn't an ethical, isn't a valid approach to healthcare. And I think particularly when we understand gender-affirming healthcare, we are almost encouraged by a lot of the discourse that we see in mainstream media and society to fall back to the default positioning of non-intervention is innocuous. And I think Prof. Jackie Hall already did a very good job of explaining to us that both approaches, whether you do intervene, whether you don't intervene, there are consequences. They are potentially irreversible, and they are potentially life-altering. And we have to treat both of these with the same gravitas. We can't sit back and say, oh, well, we'll do nothing. Much like when a patient's diagnosed with cancer, we don't sit back and say, oh, we'll do nothing and we'll just, let nature take its course because this is the natural order of things. Medicine is an interventional discipline. Now, the challenge that we faced when we put together the guidelines was firstly looking at a base of evidence that, as you can understand, isn't very well developed from the context that we've received, but also where there's a need and a marginalized group of people whose representation in the field of healthcare and as a patient population has historically been a very, very prejudiced one. And to say, well, how do we serve this community? And in doing so, we recognized that the provision of care in this instance is something that has to be very holistic. It's not a situation where we can just assemble a group of primary care physicians or a group of endocrinologists or even a group of psychologists or psychiatrists and let them put together a document. It's something that we have to, firstly, in the context of healthcare, have a multidisciplinary approach, a team, a collaborative effort between all of the different disciplines. And we spread the net very wide. We didn't just stop with medical doctors, with psychologists, with social workers. We thought about the role of physiotherapists and dietitians. We thought even beyond healthcare, because these are things that influence societal policy and institutional environments. And we recognize that we need to have voices and representation from all of these sectors as well as from the patient population in question. Now, I think that the important points that I want to get across here, and again, it is just reiterating things that have already been said, but when we produced the guidelines, we weren't trying to develop a document that provides a definitive recipe for these are the steps. to treating a transgender individual in a healthcare setting, because a guideline is not a rigid set of instructions. A guideline is a framework. A guideline is a tool. A guideline is an asset that provides a point of support and a contextualization or a lens through which clinicians can apply their training, their expertise, their collaboration in order to individualize treatment for a particular patient. And this is the truth of the matter. We do it all the time. When a patient sits directly in front of us, we need to consider all of the potential influences that might be at play and all of those factors, and try to make a decision within the framework of medical ethics, as we've already heard about, that results in ideally in a favorable outcome, but that actually represents a good decision. And just to quickly explain what I mean by a good decision, is that each and every one of us, throughout every moment, every day of our lives, we are faced with a number of decisions that we have to make. We don't have the advantage of being able to tell the future. We don't know what will come of them, but we approach each of these decisions with the body of knowledge and the lived experience that we have in the moment, and we apply that to the situation and we make a decision. When we reflect on that decision, be it months or years down the line, then it's very easy to say, oh, well, with additional information, this is how it would affect that decision, but we don't have access to that in the moment. So when we speak about a good decision, it's not a decision that is right or wrong in terms of what will the future outcome be. It is a decision that is made from a position of being informed, being empowered, being supported, and it's a decision that is longitudinal. It's not a singular moment in time, but it is part of a process. And as you heard, the assessment of capacity is not a single moment in time. It is an ongoing process. And when we make these decisions, the collaborative decision that is made in the consulting room between the provider and the patient, it needs to be understood as this is a step on a path within a system of communication between myself and you as my patient, but also your support structure, also the environment around you. And in the case of children and adolescents, not just the multidisciplinary team, but parents, but schools, but the rest of the environment. And it is a moment in which we try not to make what will be a right decision, but what will be a good decision. And I think when we understand all of the individual nuances and scenarios that play into this, you'll realize, certainly even with adults, there was no way that we could define a set approach that is usable and correct in every single circumstance, but especially so much more so with adolescents. What we did understand, and the reason that we mentioned and addressed adolescents under the heading of informed consent, under the heading of psychosocial care, and under the heading of medical intervention, was we recognized that one cannot ignore all of the nuance and all of the individual scenario and say, well, you cannot render this kind of care to anyone because it's dangerous, because that is a blatant untruth, and there is no evidence to support that kind of a position. And similarly, when I make the example of HIV treatment to say, well, no antiretrovirals for anyone as an absolute blanket position, I think we can all see the shortcomings with an approach like that. So what I ultimately want to say in regards to this is just that assembling the guidelines wasn't just a matter of we plug into ChatGPT and pull all of the articles and assemble a bibliography. It was getting a team together of people who do this work on the day-to-day, who have a wealth of experience. And I'm not talking here about expert opinion. I'm talking about experience in working in a collaborative and multidisciplinary fashion and in a longitudinal fashion, and assembling them around a table and saying, well, how do we form a starting point, a framework, something that people can refer back to, but that will give them the tools to apply their knowledge and medical ethics to an individual situation and go from there, and know that there is some kind of publication that does have their back and that has performed some of their research, but also knowing that this is a living and breathing process and something that does continue to be revisited over time. So in terms of what I will close with saying is just that as we sit here and we have this conversation, and I think it is an important one, I would urge for all of us not to render ourselves short-sighted, not to ignore all of the complexities and the nuances, to scrutinize the decisions that we make and say, you know, not are we making right decisions, but are we making good decisions? Are we empowering the people that we work with to make good decisions? And are we supporting our colleagues in order to continue making good decisions, which we don't do through litigation, referring again back to Prof. Blockman's presentation on the diffidence and the providence and the paranoia around all of that. These are not good decisions. These are decisions informed by external factors that are absolutely, without question, in 2025, in this world, but especially in South Africa, especially here in Cape Town, that are affected by so many other inputs and noise. And to say, well, can we bring this back to the individual, to the patient, and recognize that we have to apply everything that separates us from AIs and robots, our individuality, our humanity, our ability to think, and our compassion, in order to make those good decisions. So I'm going to close there and hand back to LGB. Thank you so, so much. And it's been a pleasure to be here.
Thanks so much, Anastasia. That's I think that's really formulated what I hope we also wanted to get across this afternoon, that gender-affirming care is so much more than prescriptions and rapid decisions around, you know, interventions. It is longitudinal. It is a discussion. And really to round that out, and I want to thank you all for your patience. We have no idea exactly what has gone down in terms of the technical difficulties this afternoon, but I want to thank everyone for hanging in there with us, and especially Michelle Carrahill, Dr. Carrahill, who's going to close this off for us, bringing the endocrinologist's role as perhaps the sort of final point to be made in this afternoon's work. Over to you, Michelle.
Thank you, Linda-Gail. And again, thank you to the Dean's Office and everybody for the invitation, and for those who have stayed around to listen through our technical difficulties. I enjoy speaking last because it does mean that most of the points that need to be made have been made. I am just going to try here and share my slides. It's saying it's preparing my slides, loading my presentation, so hopefully you'll be able to see it shortly. But really, I'm a pediatric endocrinologist. I am the person.
There we go. We see it beautifully.
Fantastic, fantastic. I'm the person that gets a referral quite far down the end of the line when somebody has presented themselves, or their family have helped them present themselves as worrying about how they feel in themselves with respects to their gender, and that it's different from what they've been called, labeled, or named. And it's a whole process that they get to before they get to be referred to us. So I have to respect this individual and their family when they come to us, that they've already been through a lot, potentially a traumatic lot, and that I want to provide the very best care for them and everything in the best interests of that child, which is great. And we've got these guidelines, and Anastasia, thank you, has done the introduction to how these guidelines are brought about. But at the end of the day, I'm writing a prescription, and it sits on my shoulders that I'm doing the right thing, the best thing for this person. And so we follow these guidelines, and there are multiple of them. There's the South African clinicians, HIV clinicians guideline that we've just heard about, which is very contextualized and localized and wonderful for us to have. But it's backed also with other guidelines, the WPATH guidelines, the endocrine treatment of gender dysphoric from the European Society, and others. And these guidelines all have something in common. They all say that this is a multidisciplinary but individualized gender-affirming care approach. I'm not a fan of multidisciplinary, actually. I prefer inter and intra-disciplinary. I think we should all speak with each other. It shouldn't just be this person has to visit so-and-so on that day, so-and-so on another day. We should all be participating in their care together. And so when I'm part of this team, I do like to have a conversation with the person's permission, of course, to engage with the other providers so that we all know that we're on the same page and we're all busy working towards their care. Saying that, the people that are involved in that care might be myself, the pediatricians, primary healthcare providers, very much so the family and the social support that is required, addressing any other mental health issues that may be present as well, and then the colleagues as needed, for example, with fertility counselling. The endocrine basis of the interventions come along when this person's been identified and then referred to me with a confirmed persistent gender incongruence, that they've already ascertained a developmental pubertal stage of at least 10 or 2, maybe even 3 in some guidelines, and that we are going to be engaging on an informed consent and assent basis, and that they are ready for this engagement. And what we'll be talking about mostly will be the one that's had the most political input and interest recently, and that's the aspect of puberty blocking. And the idea of blocking the endogenous pubertal process is it's an intervention intending to alleviate the distress of the physical puberty that is underway. Sorry, somebody's saying they can't see the slides. Can anybody else still see them?
Yes. We see it beautifully. Thanks, Michelle.
Julia, no, I'm not sure why not. Sorry, but I'm going to carry on. So it's alleviating the distress of that physical puberty. It's alleviating the psychological dysphoria, and it's reducing secondary sexual characteristic development, so further hair pattern development, further voice changes, or further breast growth. And then also to afford time to explore their process of gender identity and deciding whether this in fact is an issue that they are going to be having to deal with, or whether it's an exploratory time and in fact there is a return to being comfortable and living with their gender assigned at birth. And what we get involved with prescribing in that context are puberty blockers in the form of gonadotrophin-releasing hormone agonists, as well as other blockers that might, for example, block androgen action or suppress menstruation. And then later on, it's part of our guidelines and part of our affirming care is to provide the hormones that they require to promote the pubertal features of their identified gender, and then to physiologically, metabolically, and phenotypically align and support that experienced gender. So importantly, as I said, the blocking with GnRH are the ones that have been really brought to the attention recently. And just a little bit to go along with what we know about, what we expect the outcomes to be, and what we have concerns about the side effects profile of. We know that GnRH analogs are effective in halting the pubertal process, and we know that at least biochemically they're reversible. When you stop the injections of therapy, the hormone profile returns. We do know, and there is evidence that says there's psychological benefit. However, the later you start, the less there is benefit. And that is an important one to recognize when we do look at the guidelines and the timing of initiation of therapy. The concerns that have been brought up, and appropriately so, are those about the effects that come along with the impact on fertility. And under fertility, I should include sexuality or sexual health as well. The impact on bone health and growth, the impact on development, and then, of course, the potential impact on, because one limits the growth of the genitalia, for example, in a trans woman who may want to go on to have bottom surgery, the surgical potential for that bottom surgery later on. Interestingly, just for an example, when we look at the evidence when it comes to bone health and the lot of concern that's come out of bone health, it's so important that this is looked at because it shows us other care principles that we need to adhere to. And for example, trans women, even without any gender-affirming care or before they have any gender-affirming hormonal intervention, be it blockers or otherwise, are at already a risk of a low bone mineral density. And it's probably multifactorial, impacted on a decreased level of activity and weight-bearing, exercise, perhaps vitamin D deficiency and less sunlight exposure. For whatever reason, this needs to be explored and it needs to be mitigated. So it needs to be treated, addressed and treated. So it's really important that an individual who comes for their gender-affirming healthcare needs to be holistically, thoroughly looked at and helped as a whole person. I'm sorry that this slide appears a bit blurry, but it's a snapshot of the latest and the most up-to-date, as of May this year, review, a systematic review of the literature that's available, the evidence that's available in the use of these hormone agonists in transgender and gender diverse youth. And importantly, every time we look at a review, we look at a publication, we look at data that's brought out in the literature as evidence, I like to make sure who's doing it. So I look at the authors list and see if there seems to be any conflict of interest or any agenda one way or another, an inherent bias in the people doing the research. But then I also look to the funding. I want to see who's promoting or paying for this research, again, just to make sure that I'm not picking up on any bias that comes. So this was funded by the Italian government, looking to explore and make sure that there is safety in the evidence that comes forward. And I'm not going to go through it in too much detail because we are really out of time, but just to let you know, they really did have a good look at the evidence in the literature, and they did evidence graded. If Mark's still on the call, he'll be happy to hear. They did a very good look at the evidence going into these articles. And the summary is that it is, in fact, effective in halting puberty and improving mental health in transgender adolescents. But, and very importantly, they picked up on key areas of clinical and ethical considerations. For example, the bone health monitoring I've just pointed out, infertility counseling, in psychological support, and informed decision-making around these concerns, and certainly lack of long-term evidence that may be existing in some of those areas. And so this group that did the systematic review, did a very nice table of the aspects of care that we as endocrinologists should be attending to when we are providing these puberty blockers. And they give a very long list, and they go very detailedly through the bone health, the metabolic health, the potential cancer risks, of which there is no evidence yet. But the one I like the most, I would say, and this is really going to be my final take-home message, so I've really tried to keep it brief for us to finish in reasonable time, is the one I'm circling here. This is that each and every engagement with a family and child who comes to us for care is an opportunity to engage with them with all the new evidence that's coming out. It's an updated informed consent process, whether it's a written signed off consent or not. It's an updated informed consent process at every single engagement. It has to be documented well. Of course, we're all busy about defending our legal process, but it's for good healthcare that we are doing the right thing at the right time with the right information. And going to find out that we've got the most up-to-date evidence that is continuing to support the practice that we are offering our patients to give them their best care. And that is going to be the end of what I have to say. Thank you very much for listening.
Thank you, Michelle. And again, well done for just really synthesizing that in a very short space of time. Appreciate your expertise and again, just centering this holistic compassionate and evidence-based approach, which I think is really what we're hoping is going to be the lasting take-home message from the webinar. I'm going to ask, we've seen 2 questions come through, one in the first half, and that was directed, I think, largely at Mark. It was about data in the north versus the south. I'm going to ask Mark to just quickly pick up on that question, if at all possible. Mark?
Hi, thank you. Do we have that question?
Oh, yes.
Because I'm actually blurred. I think the question was there's 2 folds to it. The question seems to be a consideration of research done by the global north in the global south, and what are the implications of that in terms of our own population. And so thank you very much for that question. It's a very important question. And I'll put in the chat a little bit later on. There's a document called the Trust Code. And this is a code which we've subscribed to many of the ethics committees. And I'm wearing my ethics hat now from the University of Cape Town. And it's called a Global Code of Conduct for Equitable Research Partnerships. And it's been a recognition that that often the global north parachutes into the global south, does a whole lot of research for various reasons in terms of our vulnerability, our socioeconomic status, the costs, etc., and then takes that information away and either publishes it or registers medicines, as we've seen before, overseas, and we never get to see them. And so the Trust Code, what that has subscribed to is that there will be the Equitable Research Partnership set up front. And so it looks at a set of principles. There's 23, and it's around respect, care, honesty, and fairness. And when you look at all of those points, what you're trying to do is to protect the integrity and the rights of our participants, make sure that consent's appropriate, they're not made more vulnerable, there's proper communication, that there's fairness in terms of our investigators being able to be part of the authorship, be part of the post-trial care processes and the experiences, care for our participants, and then honesty around what is published, what the transparency is about. And so when you start looking at those 23, and you have an ethics committee that is considerate, and I think that's where we must be held up to account, is that the ethics committees reviewing this research must take care and be considerate about our population. Is it prioritized? How vulnerable? What will happen? Is the information staying with us, etc.? And has the justice issues been dealt with? And so we subscribe to the Trust Code, and I'm hoping all the other ethics committees do that in terms of protecting not only our participants but our researchers as well. I'm not sure there's a second part to that.
Yeah, you'll see the question now in the chat there, Mark. I think you've broadly answered it. I think the concern is around safety of research regarding particularly transgender individuals in the global south, seeing that gender-affirming care is highly politicized and demonized in many regions. So speaking towards data manipulation, research that is not in the best interest of transgender individuals in the global south, and perhaps even globally. So
I think that what these conversations are highlighting, Linda-Gail, is the opportunity for the discourse to be discussed by the role players. And the role players and what have been tasked here, there's 2 role players here. One is the ethics committees, and all the ethics committees are aligned in terms of their thinking around protection of participants, protection of investigators that want to do this research, and what does the community say about this research? And then a more difficult issue is that at what level must this research be approved? For example, must the Ministry of Health give approval as well? Well, if that's the case and there's risk, well, maybe we must take away that approval from the Ministry of Health, and we must hold that within our own environment and with community advisory boards, and think out the box in terms of how we safely protect all, because this research is so important. And we've done that before in our institution for various research processes, and I think that, and studies. So I think it's about opening up the conversation and getting the correct people around the table, and then planning what it could look like, and making decisions. And then farming, that's about, and the way evidence is reviewed. I think we must be honest and true to, as I said, from a critical appraisal point of view. So Michelle would put up a systematic review, and what we would do is that we would say, is it a high quality or low quality systematic review? Have they been honest about it, and has it all been graded? And can we find the data that made up the systematic review and appraise it ourselves, and actually look at all those studies? And then if we have a high quality systematic review, I did hear from Anastasia that that it may be hard to utilize that in our own country. Well, we have adopt, and there's a new process of adopting and taking on board what is happening in our own environment and what has been done in other environments. And is there a way to get this to resonate so we don't have to reinvent the wheel, especially for urgent decisions? So I think it's about a conversation, understanding the discourse, and getting the correct people in the room to take this forward.
So Mark, I'm going to push you a little bit. Dr. Giddy is asking, because given what you've just said, she's asking, what do we do when another systematic review comes out that maybe is counter to, a previous systematic review? So what happens when evidence seems to be at odds with each other? What do we do under those circumstances?
Yes, so we need to go back to first principles, and we must. A very good colleague of mine at a meeting once said to me, "I'm glad we're all talking about the same evidence," and I think that's where we must start. Have both systematic reviews incorporated all the evidence? If that's not the case, and that's why I said there, you should bin even if it comes from high impact journals, you should bin it if it hasn't done that. And so what you have to do is you actually have to look out yourself, scope it, and make 100% sure that the systematic review, in terms of their PRISM processes, have actually not left out data and haven't farmed the data for their own requirements. And then you can compare, and there shouldn't be a difference unless the question you've asked is different. And so you need to really look very hard at what is the question up front, and you can't change the question halfway through. And so to suit yourself. So I think there's ways of looking at those systematic reviews and seeing the honesty and the transparency of them. And then you've got to question, why was the one not incorporated in the other? And so it's about honest look and critical appraisal.
Thank you. Thank you. I'm going to actually move on. Thank you, Mark, to Karabo. There's a question on sort of legal recourse that comes to actually outside of the child or youth, more into adult around employment. And the questioner puts a case forward of somebody sounds like it may be an individual with intersex. They have both male and female genitalia. The individual identifies as male, but all formal documents they have are female sex assigned. This has resulted in the person being denied work on the basis of this. And so what is the legal recourse in this circumstance? Maybe Karabo, you could just volunteer some thoughts.
Yeah, I mean, from my view, I would say that there are two issues. The one is in relation to the documents that have the female identifies the person as female. They need to decide whether they want to change that, and I mean, there are legal processes for that. If that's something that, if they identify as male, they think will help them. So that is that one. The second issue, it relates to, will be a labor law issue. I think if people are discriminating against you when you applied for a job and there's nothing in the job that really requires to be a male or a female, I think in our country, we have a lot of cases about non-discrimination in the workplace. We have the cases on HIV and discrimination. So that'll be a case for discrimination. It's a tough one because the person will have to decide whether they want to challenge the particular potential employer and take the whole case to court. But that will be their recourse if that persists. Thanks.
Thanks, Karaba. I think that's helpful to break that down. I'm going to turn to Anastasia. There's been a question about the guidelines. Do you want to just say where they can be found? And also maybe just a few words about, do they cover the aspects of community care, specifically family, school, etc.?
Yeah, I'm actually going to put a link to the guidelines. There's an expanded and an abridged version. I'm going to link the expanded version, just in case you need a lot of reading for your bedtime or bathroom visits. But you can read the shorter one if you want. And yeah, just a very important question around community care, family, schools, and so on. And you know, to say that the guidelines actually are a document regarding the provision of gender-affirming healthcare to adult patients. We do include some sections on adolescents, as you'll see. A lot of the institutional guideline and sort of policies or suggestions or ideas that we incorporate are referring to settings like hospitals or prisons and so on. We do have a little bit around schools and higher education institutions, so that is included. And then, of course, the psychosocial care and the sort of context around the adolescents and the children does address family, school, community, and broader society. So yeah, we have recognized the importance and tried to incorporate those aspects. Thanks for the question, Buchle.
Thank you very much indeed. And I do want to just again thank everyone for their great inputs. I think we are going to have to wrap up here simply because we are absolutely out of time again. Thank you to everyone for sticking with us and taking us beyond the technical difficulties. I'm sure you will all agree with me. This has been an extraordinary panel of people who I think really have much to offer in helping us navigate a complex issue, but a very, very important one and very relevant to our healthcare service. And with that, I really want to thank Tracy and Lionel from the Dean's office, and of course our Dean and all of the team behind the scenes for putting this together. And I'm going to ask Lionel just to bring us to a close. Thanks, everyone.
Thank you very much, Linda-Gail. Sawubona, I want to start with that invocation of the Zulu greeting, which speaks about I see you. And so as we say Sawubona this afternoon, even though it is at the end of the gathering that we've had, it really is a moment of seeing each other. And I want to recognize it as this meeting has gone on, as the seminar has gone on, my deep sense of seeing both the patients and the people who present in need of gender-affirming care, but also for the caregivers who encounter them in the various settings. And then as a university, this is often a really unique space to engage with the evidence. I embarked on a PhD more than 10 years ago now, and one of the things that happened is that in trying to work out what social accountability is, I asked communities how they hold their doctors accountable for what they do or don't do. And in that moment, they were able to reflect back to me the fact that their notion of social accountability really resided in the relationship between the doctor and their patient at the time. The people who I spoke to spoke about this moment of vulnerability in their relationship with their healthcare professional. And so for me, it reminds me in this conversation that at the level of care, communities were describing this reciprocal community of relationships, where how they related to the doctor, the healthcare provider, and how they related into the community formed almost this triangle of interaction between the various relationships that exist. And so I don't think it's different in this issue that we're discussing today, and I really want to thank all of the presenters and Linda-Gail for your contribution today in kind of teasing out a little bit of the approach. Because what we've done today in this deanery-led seminar is focused on the idea that there is evidence out there. How we use the evidence may depend entirely on our relationship with the patient in that particular moment. So I think that that's a really critical thing for me, this idea of a reciprocal community of relationships. Because those same communities spoke of the consultation as a place of love and respect. And their notion of love and respect was less about a cuddly emotional feeling, but the sense that that was a place of collaboration so that they could share the care that the doctor decided or that they jointly decided could benefit the patient. And so many of you today have spoken about this idea of collaboration with patients and conversations that respect the patient's position in autonomy, beneficence, and a sense of justice. I really appreciated Jackie's statement that there's no hierarchy to that reflection, and they're really all equal ideas in the reflection of what the patient's position is. Many of you referred to the fact that tomorrow is Heritage Day, and so raise this idea of the long journeys that we've taken to reach where we are. And I suspect, and thanks very much Tracy for curating this conversation today, that in fact it's the start of continual conversations, difficult areas of conversations, but a conversation that I'm very mindful that we have to learn again in the faculty to have conversations in which there's a sense of mutual respect, and that our polarities on conversations don't depend on things outside of the evidence that both people are able to share, but more importantly, that we use the evidence in a weapon kind of process of not allowing patients to access the care that they might have. And I think we've really engaged today. A number of the speakers have referred to the nature of evidence across a number of spaces. But colleagues, I want to just pick up a couple of things that I found were really instructive for me, both in terms of forming my engagement, of continuing to form my engagement with this issue, but perhaps more importantly, framing the conversation that we as a faculty have to curate. I noted at the very beginning the responses from the transgender participants in Sorrel's work, the statement of the day is very long. And I think that lingers in so many of our patients' experiences, that the day is very long, both in terms of their vulnerabilities, but also in their very complicated and complex interactions with the health system. But Sorrel also left us with the idea of warning of the danger of narrow narratives of risk and trauma, that we also get caught up in the particular narrative that we may choose or how to see things. Mark's reflections offered us this idea that the evidence often resides in both the production of the evidence and the perspective of the practitioner at the point of the delivery of care. And really, in the first instance, that it is in those interpersonal relationships that the best decisions can be made. But throughout this afternoon, that we were recognizing that no two children are the same, and each of us needs to reflect on the context in which care is happening and how we can engage. I found Jackie's reference to that Applebaum and Grissow capacity assessment process a useful framework in which to engage with how we make the decisions in the various spaces that we occupy. And so, Anastasia, I think your presentation was very far from boring us, whether you had a PowerPoint or not. We were not likely to be bored by what you said, because again, you've drawn us into the fact that these guidelines are more than a list of evidences. They're really an engagement with the evidence located in the communities that we serve. And I really want to appreciate that contextualizing of those guidelines. Michelle, your emphasis of shared decision-making brings me back to that original framing of collaboration and shared decision-making that is so critical. And so, colleagues, as we head off into the evening before Heritage Day, I'm reminded again that our heritage is an important story to tell. But even as we curate these kinds of conversations, we're creating the frames through which we predict how we have conversations in the future. Too many of our conversations are characterized by blame and characterizing the other as extremely different, and so creating poles which are not always important for the conversation going forward. And so as we close this evening, I want to say in the words of the first people of this area, call this area Kamirorichais, which is place of the stars. And I think as the colleagues have spoken today, they've really reflected of the enlightenment that we can gather from each other in this place of the stars. But as they would say, in gratitude for the work that has been done, Kaisikai Gangans. Thank you very much. Have a happy Heritage Day.
Thank you, everyone.